Good afternoon, everybody. Welcome everybody to come back to the home for the next session. This morning we have seen and heard many lecture and especially the very interesting cases. And in this afternoon, we will begin this session for the examination of hyperkinetic movement. I'm very honored to be here with you to moderate this session with Professor Lin Tian. And for the beginning of the session, I would like to introduce Dr. Jorada Singran from Chulalongkorn to present the topic of how to examine the patient with hyperkinetic movement disorder. Please, Dr. Singran.
Okay, thank you for your introduction. And again, hello again. In this afternoon session, I will come back with the session of how to examine patient with hyperkinetic movement disorder. And this is the outline of this lecture. Is also how to examine tremor, dystonia, chorea, myoclonus, and also functional movement disorder. Some detail we know in the morning session already. And I would like to recap again for the definition of the tremor is the rhythmical sinusoidal oscillation movement, which is the oscillation is one of the key of the definition of the tremor. And also I would like to emphasize again, tremor is the most common form of involuntary movement disorder in adults. And we can classify into rest and action can be classified into kinetic and also postural and isometric. The kinetic is the tremor occur when we have an activity, and we can test with like the finger to nose test. The simple kinetic is the tremor that occur or the distance from the beginning to the end point. And intention, like we see in the cerebellar dysfunction, at there you will see the tremor at the end of the target, and also some task specific. For the postural is also position dependent and independent. Another one is the isometric tremor, which is you won't see the movement in the glass, but actually your muscle as contraction, like you hold the grass or the bottom of water, you didn't move your arm, but your muscle also contract and have a tremor. This is called the isometric tremor. And a little bit tip for the tremor examination according to the body part. For the rest tremor, I usually I already talk in the morning. And the second is for the postural. First, you ask the patient to extend the patient arms in the outreach position in the pronate, and then ask them for supinate. And then maybe you ask them to perform like a bend of their elbow, like a wing beating position. And for the evidence of the kinetic or intention tremor, you perform the finger to nose test. But the key is you have to ask the patient to reach to the end of the distance of the patient arm to see all the component of the kinetic tremor. And also you have to look for other feature like dystonic posturing, another Parkinsonism, and also cerebellar side that also quite common to occur together with the tremor. And this is like for the history taking scope that can lead you to the tremor consensus that we will talk later. You might get from the history like the part of the body that have tremor, how long did you notice it, under the circumstance like action or rest, and where is the tremor spread, what the temporal cause of the tremor, is its impact your physical or social or not, and do you have other neurological or systemic condition or other medical use of family history. As I talked in the morning, from the tremor consensus in 2018, we classify into two axes. The axis one also the clinical characteristic, and the axis two also etiology, like in dystonia classification. And this is different from dystonia a little bit. For the axis one of the tremor, you should get the history feature like age of onset, temporal onset, alcohol drinking, and the sensitivity of the alcohol and drug, and also the past history, family history, and you have to get the tremor classification like body distribution, activation, or frequency that you have to notice. And another one like you have to know the associated sign like other neurological or systemic sign. And the last one, the additional laboratory test, for example, the electrophysiological test. And the axis two also etiology, which is usually acquired and genetic, and also maybe idiopathic, familial, or sporadic. And when you get the information from the axis one, and then you can group or summarize into the tremor syndrome. For example, the action and rest tremor are the predominant side in the essential tremor or essential tremor plus, or either enhanced physiological tremor that I cannot go deeply into every tremor syndrome. And the second one might be focal tremor. The third one is task-specific tremor. The next one might be orthostatic tremor. And you have to look for the tremor with prominent additional sign or other. So I recap this video again for the tip of the examination of the essential tremor patient, or might be the prominent postural or kinetic tremor. You not only perform the tremor test with only the postural or kinetic. Another effective or quite good test is handwriting. In the severe essential tremor, they like illegible handwriting in or the big one with the shaky characteristic. Or you can test patient to water pouring to test their capability, and the water usually split out from the grasses. And you can use the Archimedes spiral drawing. It is usually the axis of the tremor amplitude, like the 60 degree in the case of essential tremor. It's easily that you can spot the shaking of the tremor on the spiral. Okay, let's move to the next video. And I will ask you what is the diagnosis in this patient. If anyone want to volunteer to guess the diagnosis, please raise your hand. As you will see that he has a rhythmic oscillation when he used of his hand when he used the scissor. But in another test, he can perform it perfectly. And this is the task-specific tremor, which has several forms of the tremor depend on the situation. The primary writing tremor is the most common form of the task-specific tremor, but the tremor can occur in the patient who specialize in motor skill and practice over and over and using this body part repetitively. for example, the musician, the golfer, and seizure like in this patient. And the next case, oh, I have the answer. He's the 15 years old boy with an history of like little finger tremor. He only complained of this tremor on his little finger for 3 months. He also has a normal cognitive and mood, normal perinatal history, no family history. But on the examination, apart from the tremor that you see in this video, we found a little bit very mild rigidity on the right arm. And for the eye examination, you will see the yellowish or grayish in the upper limbus of this patient, which is the KF ring. And the serum ceruloplasmin is quite low, around 1 to 2. And his diagnosis is the Wilson disease. So another rare tremor syndrome is, you will see in this patient, he in the position of the wing beating, like the bend of your elbow and stretch your arm. And the tremor is quite high amplitude in the proximal distribution of the arm. This is the wing beating tremor, which is, we can see in this tremor in Wilson disease too, but not all of the Wilson disease patients need to have this tremor. So let's move to another part of the tremor, like neck and legs. For the neck tremor, it might be in the direction of no, yes, or in multi-direction. And you have to look for the maybe subtle dystonic posturing like an torticollis or the shoulder elevation, apart from the examination. That will be maybe more prominent when you see the patient when they're walking, and the subtle dystonia will be more elicit. For the leg tremor, it can be classified into rest tremor, that you have to ensure that the foot of the patient flat on the ground to be the true resting. Is you have to support the body part that you have to test, because if it didn't flat on the ground, it might be when the patient extend the ankle, it might be the cronus that you see, like the rhythmic movement. And for the postural tremor, you can ask patient to walk or no, not to walk, to stretching out his or her leg or standing. And the last one is observe the tremor when the patient walks. So, and you see the 60 years old woman, she complained of the leg tremor for 1 year on her left leg like this. Actually, her foot didn't press to the ground for the whole of her foot, but she has the tremor. As you will see the rhythmic oscillation in side by side. And when I try to press her foot on the ground, the tremor decreased, but still have a little bit tremor. When I, in the third, and for the bradykinesia, I think she also have a little bit bradykinesia on the left side. This is the toe tap At the beginning, when I saw the first video that my friend sent to me, I'm not sure this is the real to resting tremor or not, and then try to do many positions. Another, apart from the my bradykinesia, she also have a rigidity on the left side. So I tried levodopa in this patient, and she returned with maybe 50% of the clinical response. So let's move to the leg tremor. For the rest tremor of the leg, you should think about the Parkinson's disease or another dystonic tremor that can cause the tremor on top of the dystonia. And another mimic might be clonus that you have to keep in mind. For the standing, most common is the orthostatic tremor. For the fast frequency, is around 13 to 18 hertz. It usually is called the characteristic of the idiopathic orthostatic tremor, and sometimes it associates with other neurological disorder like Parkinson's disease. It's called OT+. And for the slow frequency, like less than 10, it usually associates with other neurological disorder more common than the fast frequency. And for the walking tremor, it's quite very uncommon. Maybe some part with the cerebral disease, with maybe often with the truncal dystonia, and sometimes the walking tremor should consider for the non-tremor cause like myoclonus or another like functional movement disorder. Okay. And this patient, you will see that she has an abnormal posture on her neck with a tremor on top. And sometimes tremor when on her hand. And she is the dystonic tremor, which is a spontaneously oscillation, rhythmical, and although often inconsistency pattern movement produced by contraction of the dystonic muscle, and maybe exacerbated by the attempt to maintain in the primary posture. So this is the comparison for the essential tremor, Parkinsonian tremor, and also dystonic tremor. Let's move to the next one. Which, after you see the video, which one do you think has the essential and which one do you think has a symptomatic? Okay. For the first patient, you will see the rhythmic movement of the whole palate. And if you carefully listen, you will hear the ear click sound. It's like click, click, click. It's very small. And sometimes he can stop the movement. The first patient is the essential palatal tremor, but in the second patient is you not only see the palatal tremor, but also have a tongue tremor and also have another neurological sign like a tongue deviation. Is the symptomatic palatal tremor with the lesion in the brainstem. So what is the palatal tremor? this is the rhythmic movement of the palate, and it can subdivide into essential and symptomatic. For the essential tremor in the patient, number one is the absence of the region, and you will find in some patient with voluntary movement in the essential palatal tremor. And this muscle that affect is the tensor villi palatini, the insertion of this muscle insert at the eustachian tube, so you can hear the ear creak in the essential palatal tremor. And for the symptomatic palatal tremor in the second patient, it usually have the lesion in the brainstem in area of Gillian-Morelet triangle, with include the red nucleus, olivary nucleus, and also dentate nucleus. And this is the muscle that involved in the different muscle from the essential tremor, so you didn't hear the ear creak in the symptomatic palatal tremor. And this is another cranial tremor. For the tremor examination, you have to keep in mind that might be other tremor mimics. For example, cortical tremor, which is actually the cortical myoclonus, that quite rhythmic, that can be found in familial or idiopathic, maybe in MSA. The another one is the atitosis. The atitosis is the distal hand dystonic posture and also in choreiform movement, but sometimes it can manifest like rhythmic, so it might be confused with the tremor. And another one that I mentioned is the clonus. For the dystonia, as the sustained or intermittent muscle contraction that cause abnormal posture and repetitive movement and posture. Again, I will show you the generalized dystonia patient, which is involuntary, relatively sustained or intermittent muscle contraction, and usually produce the twitching that you will see that in her neck, her arm, and her trunk, which is the twitching and repetitive of the movement with an abnormal posture. This patient is the generalized dystonia from the cerebral palsy, from the birth asphyxia. This cerebral palsy can cause the delayed dystonia. Apart from the abnormal posture, other phenomenology or sign that we should look for in the dystonia patient, like for example, the outlying spasm, muscle hypertrophy, the directional preponderance, the variety of dystonia with the changing of the position. And usually dystonia increase with the voluntary movement. And sometimes it worsen with the stress and fatigue. And sometimes it improves during sleep. For the cervical dystonia, sometimes we will see the interesting sign. This is called sensory trick. You will see this severe cervical dystonia patient, and he said that he just touched his nose or his face, and then the position can be collected, and this is called sensory trick or just antagonist. This is the voluntary action like tactile or proprioceptive that correct the abnormal posture or abbreviate the dystonia, and sometimes imaginary sensory trick can also be effective. And again, this is the dystonia tremor that we allow the tremor can fall together with the dystonia. And this one is the example of the writer cramp patient, which is one of the task-specific dystonia. She didn't have any dystonic position in every situation except for when she start to write. You see that her arm is straight, and then the abnormal posture overflow to the elbow and sometimes to the shoulder, which is called the overflow of muscle contraction. And when you ask her to write in the left hand, and you notice on the right hand that has elicit the dystonic posture, which is the Miller dystonia. Okay. Again, for the axis of the dystonia in order axis 1 and 2, like I mentioned in the morning. Okay, let's to next patient. She is the 40 years old female and feel like her leg is contract and has an abnormal posture when walking, usually in the evening for 4 months. And she has normal walking in the morning. Other no pain, no weakness. She has doctor with no more normal cognitive and no other past medical condition. And she has a family history of her grandfather's suspect diagnosis of Parkinson's disease at the age of 80 years old. You will see a little bit abnormal posture on her left leg, very mild, like the internal rotation of her ankle. And sometimes it looks like she has weakness on her left leg, but actually we test the weakness. She has no weakness. For the diagnosis of this patient, she has a dopa responsive dystonia with the prominent feature of dystonia and Parkinsonism, and also have a diurnal variation. The onset usually in the childhood in the classic GCH1 mutation, but maybe adolescent or adult in another mutation. And it's for the GCH1 mutation is inherited in the AD her inheritance. This is the rate limit. The mutation is affect the rate limiting step for the theta hydrobiopterin, which is the pathway of the dopaminergic mechanism synthesis. So, and the treatment is just the low dose of the levodopa, and one of the characteristic of the dopa responsive dystonia is the sustained response to low dose levodopa without the motor complication in the most classic DRD. But now we have many genes that causing the DRD that were found, not only GCH1 mutation, and making the clinical presentation of the DRD is quite varied. For the chorea, this is the irregular, flowing, and non-stereotype, random, and of involuntary movement. Again, chorea is quite random. So the examination of the chorea, you have to look for the phenomenology that I mentioned. And sometimes it might be very mild that resemble like an only restlessness. And for the proximal and large amplitude, this is the balism that I show you in the morning. And sometimes chorea can worsen by anxiety and stress. This is the 2 patients. The first one I show you in the morning with the Huntington disease. And the second one also have a very mild chorea than the left one. You will see that she have an irregular flow light in her finger, her foot, sometime in her face. She also was confirmed of Huntington disease too. So it might be the spectrum of the one disease. Another is the parakinesia.
This patient with HD
You
generalized.
He also a Huntington disease patient and have a generalized chorea, but you will see that he frequently touch his glasses, his mouth, or any part of the body. This is called parakinesia. This is voluntary or semi-voluntary movement, such as touching the face or adjusting some part of the body to hide his chorea. This is called parakinesia. Another interesting examination for the Huntington and sometimes found in Sydenham chorea is called hung up reflex. This patient has a Huntington disease, and when you perform the knee jerk, you will see the delayed relaxation of the knee, which is the hung up reflex that can be found in Huntington disease and sometimes in Sydenham chorea. For the examination step for the chorea, you have to look for the feature to exclude other like pseudoathetosis, which can be look like chorea, but it is from the impairment of the proprioception. It may be more severe when the patient close their eye and impair the proprioception test. And then you can determine the distribution of the chorea and try to find the other side. And this is the huge risk of chorea, cause of chorea. Maybe you can divide into hereditary or acquired, and then you find another possible cause. The cause of chorea is usually from the general medical condition like SLE or metabolic disorder. And the next one, you will see chorea on her right hand, which is the hemichorea. That you keep in mind that hemi lesion, you might think about the contralateral structural lesion, or maybe some metabolic like non-ketotic hyperglycemic chorea. But the answer of this patient will be in the next session. Okay, let's move to the myoclonus, which is the brief, intermittent, shock light, and jerk light. You have to identify this. Is the true myoclonus? Myoclonus is negative or positive. And what are the clinical characteristics of the myoclonus and anatomical and etiology? You have to keep in mind that myoclonus is the clinical sign, is not the diagnosis. Again, I would like to recap for the classification according to the clinical classification and physiological classification. So this is the example of the cortical myoclonus, which is usually in the distribution of the distal limb and action induced. This patient have a hepatic encephalopathy when he stretch out his arm like this, and then have a postural lap, which is called the negative myoclonus. Or you might be sometimes, like asteresis, can't remember. And for the subcortical myoclonus, the distribution is goes to your axial and your body. In this patient, it's quite common for the consultation from the medical department, like after he has the cardiac arrest, and then you can resuscitate our OSC, And after that, this patient developed the jerky movement like this. It's usually generalized multifocal myoclonus, maybe predominantly axial and sometimes proximal part of the arm and leg. And this is the post-hypoxic myoclonus, which is the poor prognosis in the patient with cardiac arrest. They have two forms of the post-cardiac arrest myoclonus. The previous one is the immediately form. The next one is the delay form, which can cause the axial myoclonus and sometimes with a little bit intention limb myoclonus, but the axial is prominent. It's called the Lance-Adams syndrome. The patient usually has a like bouncing gait that I show you. He also have a stimulus sensitive myoclonus too. And the myoclonus predominantly in the axial. All right. It's very difficult to stand. Oh. So again, this is the distinct feature of the hyperkinetic and the examination. To the last one, I show you in the morning, which is the functional movement disorder, and also in this patient. He also has a tremor on his right leg, and waxing and waning, and sometimes it's distractible when he perform another volitional movement. Yes. For the functional movement disorder, the clinical clue might be acute onset, waxing and waning, changing in movement over time, and maybe can migrate from one part to another part, and maybe absent of the should be his sign in the circumstance disorder, and maybe have a history of psychiatric disorder, and maybe get a secondary gain. For the examination, it might be different tests to perform. For example, the distraction with the movement can disappear when with the distraction that I will show you in the next video, and reappear again when the nothing to focus. And the movement can vary in the frequency and entrainable. Sometimes fake dystonia might be one of the suggesting feature of the functional movement disorder. For this patient, she has a functional movement of tremor on her right hand.
I'm sorry, Dr. Sringan, we had overtime, so you can speed up. Thank you.
Yes, thank you. And this is the distractible. We asked her to perform the hand open and close, and the tremor is disappear. And this is the entrainment. We asked her to perform the rhythmic movement, and the frequency of the functional side will follow the same tremor as the voluntary side. Like this is essential tremor, as entrainment, sorry. And this is the list of another possible functional tremor. And this also take home message to examine the hyperkinetic to find the prominent feature, look for the mimics, and also be careful for the diagnosis of the functional movement disorder. Awesome. Thank you.
Thank you very much, Dr. Girarda. Very excellent overview on the how to examine the hyperkinetic movement disorders. Maybe we can allow one question in because of time.
Try to.
Are there any questions?
Thank you for your very interesting presentation. And how about the differentiation between tremor, essential tremor and tremor caused by hyperthyroidism?
Yes. For the from tremor in the thyroid, hyperthyroid or Graves' disease, it usually involves the fine tremor on the finger. But for the essential tremor, like it's more prominent on the wrist, and also have a kinetic tremor, which is quite different from the hyperthyroid tremor.
Okay, thank you very much. I think we have to move on because of time. So next we will have the video-based case discussion on hyperkinetic movement disorders. So I'd like to invite two speakers, Dr. Supata Metarachep from Chulalongkorn Center of Excellence for Parkinson's Disease and Related Disorders, and together with Dr. Kang Chung Ngok Po from the Movement Disorders Unit Neurology Department in this hospital, University Medical Center, Ho Chi Minh City, Vietnam. So can we welcome them?
So good afternoon, everyone. It's an honor and privilege to speak today. And thanks for a very warm welcome here. This session is a video-based case discussion on hyperkinetic movement disorders presented by me and Dr. Huang Wo. And we will show many interesting cases and discuss the phenomenology of the movement and the possible etiologies. I'm Supata Metarachep from Chula PD Center. Let's start with the first case. This is a 30-year-old Thai female patient presented with an acute onset of abnormal movement on her right arms and leg. She cannot control the movement and deny any urge to move. The second video, the doctor asked her to walk and turn around. You can note the abnormal movement on her right arm and leg.
หมุนกลับได้ไหมเดินกลับไปถึงตรงโน้นเลยแล้วก็เดินกลับมาใหม่
So what is the phenomenology in this patient? So I will recap. From the video, you can see that this is a hyperkinetic continuous flow of random movement, non-rhythmic movement. These movements are involved both in the proximal and distal of the right arm and leg. And some of them are slow dance-like movement, and some are mild, violent shrinking movement on the proximal part, and it involves just only on the right side. So it's hemichorea hemibarism. This is a spectrum of the chorea. Acetosis, chorea, and barism are spectrum disorders. They can be hyperkinetic. They are also the hyperkinetic, involuntary, and non-rhythmic movement. Acetosis tend to be involved in the distal parts of the limb and characterized by writhing and slow movement. And chorea is a character by dance-like movement that fall from one body part to another. And finally, barism typically involved in the proximal part of the limb and more rapid character as the violent thinking movement. And in this case, the chorea is involved in only one side of the body. So from this body distribution, the structural cause like vascular disease, stroke, and others should be considered. as well as autoimmune consider can be present like this too, like in Vietnam, Korea. So we do the investigation and it show a high assay titer and a throat swab culture was positive for Streptococcus. So we diagnosed of the Vietnam, Korea for her and she was treated with the penicillin. But however, the movement still relapsed. So she went for the further investigation. This is the fly-MRI blend demonstrate the old infarction in bilateral frontal lobe and also the prominent leptomeningeal collateral result in a view with contrast enhancement and a high fold on the fly due to the slow fold. These are called IV side.
Do you want the audience to maybe make a guess first?
Okay.
Yeah.
Okay.
So
I think the guest can guess what is the diagnosis. Just any volunteer.
Or anyone who disagree with the phenomenology or has other comments on the phenomenology just now. Or perhaps a differential diagnosis. Anyone? Thank you.
For me, the IV side I saw easily in Moya disease, and now I know the Sydenham Korea also have this side. Thank you for the presentation.
Does the rest agree with him? Or are there any other tests that you would like to do? What else would you like to proceed?
For the Moya, I will check the DSA, and for the Sydenham Korea, I will check the ASLO.
Should we ask the expert also? Let's ask Richard. Yes, in the case. Okay. Dr. Tai, maybe?
Talk about phenomenology. Yes, we agree with you. We can see the patient have the involuntary movement disorder on your left side, hand and leg with random, irregular, and irregular movement disorders and non-stereotype. So in and it's predominant on the distant limb. So in this case, I think the patient have a hemichorea. Yes. Of course, we must do the investigation for the diagnosis, the cause of hemichorea in this young patient. The cause of autoimmune encephalopathy or some neurovascular disease or genetic disease, we must to screen the causes. Yes. And talk about the MRI. You continue to explain the MRI, please?
Okay.
Yes.
So she was diagnosed as Moya disease, like the audience, and thank you for participation. And she undergo the CTA band, which is demonstrate a severe stenosis of bilateral supracrinoid ICA in the M1 segment, bilateral MCA. And she also do the CT perfusion, which demonstrate hypoperfusion on the left side. So this The first case is a patient with Moyamoya disease who presented with hemichorea hemibalism. This is a summary reported case of chorea associated with Moyamoya disease. Patients can be present both in unilateral or bilateral chorea with an imaging involved basal ganglia. And our patient had the evidence from these reviews. Our patients had the evidence of hypertrophy lenticulostriate collateral vessel through the basal ganglia. So that's the cause of the mechanism of the hemichorea. And moving to the second interesting case, this is a 57-year-old Thai female patient presented with cognitive decline and abnormal movement for 7 years. And she also had the positive family history of the movement disorders, her mother and her younger sister. The first video, the doctor asked the patient to stick out the tongue and hold it for a while, about 10 seconds, but she cannot do it. And in the second video, the doctor asked her to hold a grip, and she cannot do it too. This patient presents with generalized chorea that involved in her both arms, leg, and feet. But the ones I want to ask, that's what is the sign in the video, the first and second video. Anyone want to guess? Any volunteer?
What is the sign that is shown in the video?
ลิ้นออกมาอย่างกำไว้นะกำแน่นๆกำยาวเลยกำแน่นๆยาวค้างไว้กำแน่นๆกำไว้นะยาวออกมายาวๆไหวไหมยาวๆเลยค่ะนับ1 ถึง 10ในใจนะนับออกมาดังๆได้3
Okay, anyone? So what is the sign shown in the video and what does it signify?
The audience from the workshop can type in the chat.
Volunteers?
นับลิ้นออกมากำไว้นะกำแน่นๆกำยาวเลยกำแน่นๆยาวค้างไว้กำแน่นๆกำไว้นะ
Maybe we can discuss it in terms of the description if we don't know the name of the sign. Why, for example, that patient couldn't keep the tongue sticking out?
ค้างไว้ได้ไหวแล้ว
Okay.
นับลิ้นออกมาไว้นะกำแน่นๆกำค้างไว้
I think the patient has built size and ribs.
นับลิ้นยาวค้างไว้
Yeah.
ยาวออกมายาวๆนับ1 ถึง 10ในใจนะนับออกมาดังๆ
Okay, so can also let me move to the answer. Okay, so this is the motor. It is called the motor impersistence, and is an inability to maintain the voluntary contraction. The first video showed the tongue protrusion, and the second video is the movement grip, that she unable to do the constant grip. And I want to add the involvement of the chorea in her face that is very prominent in the eyebrow, and look at the features that show this. Okay, so
And
in
I think
addition,
the first one also they have been described as the flying catcher's tongue as well, the tongue protrusion. Thank you.
okay.
นับลิ้นออกมากำไว้นะกำแน่นๆ
So in addition to generalized chorea, these patients have a unique character of the chorea that involved in the forehead, in the upper part of the face. That is very specific to the Huntington disease, and from the history of this case, that is chronic progressive, and also the positive of her family history in the autosomal dominant pattern. So the diagnosis point to the AD group of the primary chorea. And she do the genetic test and reveal the positive of the repeat CAG expansion in the HTT gene. So this patient was diagnosed as Huntington disease. So this is a brief review of the Huntington disease. It's an autosomal dominant result from the CAG repeat expansion in the HTT gene, and the onset of the disease is 30 to 50 years with the anticipation, which means that the age of onset become earlier in the next generation as the result of the rising of the repeat expansion and of the offspring. And the clinical triad of presentation in Huntington disease includes the movement disorders, neuropsychiatric, and the cognition. And the most common movement disorder is in Huntington disease is chorea, which is present about 90%. And other is the dystonia, Parkinsonism, tics. This picture represents the natural history of Huntington disease that is begin with chorea, followed or intersect by the occur of the cognitive and neuropsychiatric syndrome. Okay, so moving to the third case. This is a 30 years old Thai man presented with neck pain and abnormal postures for 8 months. So we do play. Okay, so the doctor asks him to turn the head to the right and to the left. And then moving to the neutral position. And you see that the head is turning to the left. And then the patient touched at her neck, at his neck and chin. Okay, so what is the phenomenology in this patient?
So what is the phenomenology and what is the touching at the neck signify?
I think this is cervical dystonia and sensory tic.
Okay. So correct. Okay, so let me recap. This is the hyperkinetic, non-rhythmic, involuntary, and with an abnormal posture. And the action that the patient trying to lessen the severity of the abnormal postures, like touching his chin or neck or anything, like some wearing a scarf. So it's called sensory tricks, and it is the compensatory gesture of patient with dystonia. Oh, sorry. And in this case, the involved of the dystonia only in the single region, so it's called focal dystonia. And the region is the cervical dystonia, as the audience answered. And to give a specific term, the head is turning to the left, so we are called a left torticollis. This is how we approach to dystonia. It consists of the axis 1, the characteristic of the dystonia, and axis 2, the etiologies. In this our case, the body distribution is focal, just single region, and we also do the C-spine MRIs, and it's one negative. So this patient was diagnosed with primary cervical dystonia. So this is the recap of the cervical dystonia. This is the most common focal dystonia. The onset is 30 to 50 years and more common in women than men. And occasionally with the head or dystonic, the head dystonic tremor, and the neck and shoulder pain occur in 75%. And the sensory tic, like you see in the video. And broadly divided into 4 groups: torticollis, laterocollis, anticollis, and retrocollis. The secondary torticollis can be caused by the neck injury, atlantoaxial dislocation, and cervical disease, and also tardive dystonia. This is from the drugs induced these movement disorders. And in tardive dystonia, retrocollis is common. The treatment of cervical dystonia can include rehabilitation, that is the adaptation techniques, and optimizing the sensory tricks, and the oral medication, which include the drugs that involve cholinergic, GABAergic, and dopamine system. That report some benefit, but are limited by the side effect. And botulinum toxin injection that are the approved in this box is the type of botulinum toxin that has been approved. And the DBS in globus pallidus internus may be affect the treatment of cervical dystonia in some series. Other primary adult onset dystonia include the blepharospasm, which involve the abnormal contraction around the eyes, as you see in these pictures, and the oromandibular dystonia that truly consists of various of subtypes. In this picture is a jaw opening type, and the limb dystonia, such as the rider cramp, that the dystonia present while patients are riding. This table summary of the primary adult onset focal dystonia. Okay, so moving to the next case, my last case. This is a 37-year-old Filipino man presented with chronic disturbing abnormal postures. He born in the Philippine island of Panay. First, so can anyone guess describe the phenomenology or guess the etiology? Just broadly the group of the etiology is not the specific disease.
Your answer is down there. But maybe the phenomenology.
Okay, so the answer is down there. So okay, so I recap the case. Okay, so okay,
Phenomenology. Yeah.
okay, so this kind of phenomenology. Okay, so the phenomenology consists of the generalized dystonia that's in entire face, oromandibular dystonia, and the lateral correlates of cervical dystonia, and also involve the trunk. And from the history and physical examination, he also developed the Parkinsonism with limb rigidity and bradykinesia. So from the history of chronic clinical cause in this case and generalized disturbing, that is point to the hereditary causes of dystonia, which consists of various disorders. And in this case, the dystonia are combined with the Parkinsonism. So this group are the disorder that should be considered. The genetic test revealed the mutation. So the patient was diagnosed with the LUBAC, or X-linked dystonia Parkinsonism DYT3. The patient has been treated with botulinum toxin type A injection for a while, but only partially relieved, so he underwent the DBS surgery and good response. LUBAC is an X-linked dystonia Parkinsonism with clinical or focal dystonia, like in the case shown, and followed by the segmental or the generalized dystonia. And Parkinsonism developed later 50% of the case, and the endemic is in Panay, Philippines. Okay, so thank you for your attention.
Thank you very much. Any comments or questions? Very interesting cases, all the 4 cases. So you can see all the phenotype and also the underlying disease. Richard, you wanted to say something?
I thought that the video of the last patient is quite striking, and usually when we encounter that type of patient in the first instance, the problems always about whether this is a primary or the secondary form. And I think that there is certain clues on the physical examinations that you see from video might help to differentiate between the two. First is the dynamic nature, the dynamic movement of the dystonia of the patients that you see helps to support that, that might be the primary or hereditary form. You see that type of dystonia in those patients is quite dynamic. You see a lot of movement in contrast to certain type of the secondary dystonia in which it's very stiff, rigid, and fixed. And that when you see that, that usually suggests more of the secondary, like patient with autoimmune or the other secondary cause. Sometimes you see very stiff and rigid. And the other thing is the absence of the other neurological signs. But usually patients who have this type of general dystonia with a lot of dynamic movement, it's very hard to do physical exam. Usually we can do mainly with the observation and things. So just want to point out that that video is quite good. The other thing that you might want to point out about the loop back is the oromandibular and the lingual, particularly lingual involvement at the initial stage. And then
we see a lot of those when we went to Philippines some years back. We went to they brought it to the conference hall, all the patients, mainly dystonia, Parkinsonism. So this combined two features, and they get a lot of this oromandibular dystonia. Okay, we can go on to the 2 more cases from Vietnam.
Okay, thank you so much for your great cases from Dr. Supata. I am Khang Võ from Movement Disorder Unit at University Medical Center of Ho Chi Minh City, Vietnam. And today I will present my 2 cases on hyperkinetic movement disorder. My first case is a 68 years old male who admitted to our hospital because of his abnormal movement on his right arm. 10 years ago, before admitted to our hospital, he has mild dysarthria and dizziness and mild weakness on his right side. He was diagnosed with the left bronchial hemorrhagic stroke and hypertension. And after discharge from the hospital, he only had mild weakness on his right side with the modified Rankin scale was 2 points. But 4 years ago, he started to notice about his abnormal movement in his right arm. And this abnormal increased day by day and affect his daily activity. He usually used medication with Ambrad 1,000 milligrams per day, but modest improvement was recognized. And after the hemorrhagic stroke event 10 years ago, his blood pressure was under control with amlodipine 5 milligrams per day. And on examination, I will summarize the patient has just mild weakness on his right side, with abnormal movement on his right side. We collect it in the next video. The abnormal Babinski side and sensory deficit on the right side. Okay, you can see in this video, the patient has a rest or oscillation of his right arm with flow frequency. And when in the poster, still the flow frequency, but the amplitude is increased. And next, when the patient moving by in action, the amplitude of this movement increase in maximum. Okay. Can you tell me this phenomenology of this? Can you tell me the phenomenology of these cases?
Yeah. So what is the phenomenology here? Tremor, dystonia, chorea, and what type? Anyone?
Yeah. Yes. At rest, the patient has oscillation movement in the proximal and distal right arm. You can see in this video.
Yes, sir. I think he has hemiplegism.
Hemiplegism. Okay, thank you so much. And you have another patient, another phenomenology for these cases.
If hemiplegism is more flinging type of movement. So you look at the phenomenology at rest and also at posture, and he gave a hint there. You You want to play that again at the one at rest?
Play again.
Yes, I will play it again. Okay.
Okay, may I try?
Yes, please go ahead.
I think this case is compatible with Holmes tremor, right?
Yes, yes, Holmes tremor.
Holmes tremor.
Okay, that's exactly. Thank you so much. Okay. Yes, this case is illustration of the Helmet tremor, which characterized by the rest tremor and with the flow frequency in the proximal and the distal arm. It increased the amplitude of the movement by in posture and the reach maximum when the patient in action. And this phenomenology is harmless tremor. And we check again the patient's imaging with the all lesion in the hemorrhagic stroke at the left one side, as you can see in this MRI. And once again, I want to remind you about the one of the most important neuroanatomical regions in that causing this phenomenology is the Guillain-Barré triangle, which consists of the ipsilateral dentate nucleus, contralateral at the red nucleus, and the contralateral inferior olivary nucleus. And each in any damage in this nucleus or any damage in the tract connection between those nucleus can cause this abnormality. Okay, and one more questions about, can you tell me some phenomenology that have the same phenomenology like Holmes tremor that has the characterized that the rest tremor, action tremor, and postural tremor that you need to be differentiated in the clinical examination? Can you tell me? One of more specific have this maybe have some overlaps with the Holmes tremor in examination. Okay, can you tell? Okay, I will show the answer. It needs to be differentiated between Holmes tremor and limb myoarrhythmia in clinical examination because of these two phenomenologies have the same presentation, like in the rest tremor and posture tremor and goal-directed tremor with the flow frequency. As you can see in these images, Holmes tremor reach increase the amplitude of the movement, abnormal movement when in postures, and reach the maximum amplitude in goal-directed. But in limb myoarrhythmia, when the patient in postural or goal-directed, the amplitude maybe remains unchanged or mildly modulated. Okay, we will next. Here's the abnormal movement of this young man who admit to our outpatient department after 6 months after thalamic hemorrhagic stroke. As you can see in this video, the patient has a semi-rhythmic oscillation in his left arms with dystonic posture, and the semi-rhythmic oscillation of his left arm remains unchanged during at rest, posture, and goal-directed. And this patient have the diagnosis with limb myoarrhythmia. And you can see in this table, the Holmes tremor and limb myoarrhythmia still have the same etiologies. Usually after the ischemic stroke or hemorrhagic stroke at the brainstem and the Guillain-Barré triangle. Okay.
Yeah, it's normally a very slow tremor, about 2 to 4 hertz. You can get it after a stroke, whether it's hemorrhagic or infarct, but you also get it in cases like NMDAR encephalitis, especially at the facial region there. So that has also been described.
Yes, yes. Okay, thank you. And nowadays, because the Hermes tremor, it causes a very disability for the patient. Therefore, the groups of authors suggest the possibility algorithm for the treatment. We can use the first line therapy like levetiracetam, trihexyphenidaine, or levodopa for treatment of Hermes tremor, or using the second line with the clonazepam or botulinum toxin injections, or combination of steam medication. In case of refractory of Hermes tremor, some authors suggest that DBS, especially in the GBI and VAM, for the control the symptoms of Hermes tremor. Okay. I will moving to the last case of my last cases. My last case is about 57 years old male admitted to our hospital because of his dizziness. He has the previous history of 10 months ago were diagnosed with the ischemic stroke. He has the my right side weakness residual, but recently about 2 weeks he complained about his dizziness and imbalance when walking, what we know no trauma. He has mild dysphagia, but no linguistic increase and no ear click. On examination, with my right-sided weakness and Babinski side on the right side, we can recognize the abnormal movement of the palatal. As you can see in this video, this is the rhythmic movement of the soft palate with the low frequency. And in the presentation of Dr. Shireda, you can call it is a palatal tremor. But in this phenomenology, in the 2019-17, the classification of the MDS was using the phenomenology palatal tremor, but for some other authors, they use the phenomenology with the palatal myoclonus, because just only the one muscle activate this condition. However, there's some another overlap between, because there are some the other movement associated with the palatal tremor, like the facial myarrhythmia. Therefore, some authors suggest the phenomenology is like the palatal myarrhythmia in those cases. And because of the patient's complaint of the new onset dysphagia and dysphagia, we recheck again the imaging of the brain. As you can see in this imaging, the lesion in the left midbrain, the lesion. But striking here is the bilateral inferior olivary hypertensity in the flare and T2 imaging. Well, without gadolinium enhancement, but I'm sorry, but I'm not showing here. And as you can see in this video, can you tell me what's with this imaging? What do you think about this imaging?
What's the abnormality in this MRI? Which structure is that?
Yes, so the bilateral inferior olivary with the hyperintensity in the flare and T2 imaging without gadolinium enhancement. Okay, nobody? Okay.
Yeah, I think this case is a hypertrophic olivary degeneration.
Okay, thank you so much. That's correct. And this imaging is the cause of the bilateral inferior olivary hypertrophy, and we usually call it the hypertrophy of the olivary degeneration. And this imaging, we usually see it after about 4 to 6 months after the event that the damage to the Guillain-Barré triangle. And once again, I want to I emphasize that the Guillain-Barré triangle is one very important neuroanatomical regions in clinical practice. And usually when the primary lesions that affect to the dentatorubral tract that connect the dentate nucleus and the red nucleus is affected, we usually see only one contralateral of the imaging of the hypertrophy of the olivary degeneration. But when the lesions affect the central tegmental tract that connects the red nucleus and the inferior olivary nucleus, or in some cases the lesion is SCP, we can see the imagings of the bilateral hypertrophy olivary degeneration. And as you can see in this slide, the palatal, there's many causes that cause a palatal tremor or palatal myoclonus from the idiopathic, symptomatic, or in some degenerative or in some genetic can cause the symptom. And some new variant that's maybe not variant, but the other clinical manifestation can associated with the palatal tremor. In the first video, you can see the patient has the palatal myoclonus, but the patient has some oculomotor abnormality. We can consider ophthalmopsia. Ophthalmopsia is a very disability for the patient with the palatal myoclonus, and in these cases we can cause it the phenomenology of the oculopalatal myoclonus. And in the second video, you can see the rhythmic movement of the left facials of the patient. Also after the brainstem hemorrhagic stroke, and she also had the palatal myoclonus, and therefore in these cases we can see the patient had a palatal myoclonus associated with the facial myarrhythmia. And therefore some authors suggest that the term the line of palatal myarrhythmia. Okay, and how about the treatment of the palatal tremor or palatal myoclonus? Because of the symptomatic palatal tremor does not major source of disability, therefore we don't need to treat those symptoms. But in some cases, the patient has the ophthalmopsia, we can use the gabapentin or memantine to reduce those symptoms for the patient. But in some idiopathic palatal tremor, we can use the medication or botulinum toxic injections to reduce those symptoms. And finally, before closing my presentation, I want to emphasize again, the Guillain-Barré triangle is very important neuroanatomical regions, and it can but any damage in this region can cause a very various movement disorder. You can see in my presentation from the tremor, from the myoclonus, or some in myarrhythmia, and therefore we need to be recognized early to prevent from the further for the expensive treatment for over-treatment for the patient. Okay, thank you so much for your attention.
Thank you very much for Dr. Kang for your very interesting cases, and we have seen many interesting cases from the two speakers, and we maybe it's time, so we end the session now and move to another session. Thank you very much.
So please, colleagues, we have to the seat, so we can begin the latest session of the day. I hope that after all day hard working, we are able to still concentrate to this very interesting session. It is my pleasure to introduce Dr. Warongpon Phuen-Pathon from Chulalongkorn Center of Excellence for Parkinson's Disease and Related Disorder. Her topic today is how to examine patients with gait disorders. So please, Doctor.
Thank you for your great introduction. And before we start the session, Dr. Jirada would like to say something about the questionnaires.
Just a little bit, because of the lack of the resource and the challenge in the PD treatment in our region, as we mentioned, from the initiation of the Indo-China Movement Disorder Conference. So we try to collect the information from our region. So we would like to invite you, all of you, to answer the evaluation of the awareness of the medical staff about the Parkinson's disease. So to improve the diagnosis, treatment, and also the patient care in our region. This is the two parts of the awareness of the treatment and also treatment available in your country. And the second part is the knowledge, PD knowledge questionnaire. And please, you can scan this QR code and then you please answer your question.